Hello, and welcome to our second virtual Lupus Health Conference of 2023, presented by the Lupus Foundation of Northern California. My name is Tom Bakewell. I joined LFNC in February of this year as the interim ED. The plan is to transition into the role full-time in June. This organization is an honor to work with, and we're excited to welcome you to today's conference. We have two great sessions planned for today. We'd like to thank GSK for being the sponsor of today's health conference, and we're planning another great conference that will be on May 20th. More details will be available soon. Be sure to follow our social media accounts or sign up to receive our emails so you can get the most up-to-date information. We'll also be hosting our 29th annual Outrun Lupus 5K Run Walk on September 23rd, 2023 at Campbell Park. You can sign up now. This will be a hybrid event, so you can join us from wherever you live in Northern California or beyond. Start thinking about forming a team now and help us outrun lupus. Go to our website in the events section and find out more details. We want to hear your thoughts on this conference, so be sure to complete the survey when the webinar ends. This is the only way we can hear what you liked and any suggestions of what you'd like to see in the future. Thank you, and enjoy the conference.
Thank you, Tom. And good morning. My name is Krista Dela Cruz, and I am a lupus patient and volunteer with the Lupus Foundation of Northern California. I am excited to be your moderator this morning's session. So now I will go over the agenda quickly, and then we will get started. The first hour, we have two doctors from the UCSF Pediatric Rheumatology. Our first presenter will be Dr. Taylor LaFlam, and he will discuss adolescent lupus nephritis, followed by Dr. Susan Kim. She'll be discussing the POSTERITY trial, a clinical research trial for young people with lupus nephritis. After their presentations, we will have a 15 minutes of live Q&A. We will be moderating the questions, so you can type your question whenever you want during the presentation. After the Q&A, we will have a brief break. We will then welcome Tatiana Spiegler, the patient engagement liaison representing GSK. For the second session, Tatiana will present on teens living with lupus, followed by a Q&A session. I am pleased to introduce our first keynote speaker, Dr. Taylor LaFlam. Dr. LaFlam is a pediatric rheumatology fellow at UCSF, where he also received his MD and PhD and completed pediatrics residency, along with caring for patients with lupus and other rheumatic diseases. He performs research on how autoimmunity develops with a particular interest in lupus. We are thrilled to have Dr. LaFlam here to talk to us today. Welcome.
Hello, thank you, Krista, for that kind introduction. Let me go ahead and pull up my slides. Okay, perfect, there we go. So it's a real pleasure and privilege to be able to speak today to you about lupus nephritis, and I hope to give a sense of where things stand right now and also a little bit about where we hope to go in the future. I have no conflicts of interest or other disclosures to mention. And the only disclaimer is, as you can imagine, this is all sort of general information that I'll be providing about lupus nephritis and not intended to be used as any sort of specific medical advice for any given person. So I'm going to talk some in general about lupus nephritis, talking some about what makes it distinct in children and adolescents, but a lot of what I'll be saying can apply to all ages. Then I'll have a chance to go into what we currently use in our treatment. And then we'll end with a discussion of ongoing research efforts and areas that we're hoping to see improvement in the coming years. So, by lupus, I'm referring to systemic lupus erythematosus, SLE, as are all familiar with. And I mention that because, of course, there are some other forms of lupus that may involve only the skin, for example. But in this case, with systemic, this is a situation where we have effects throughout the body. And, some of these effects, as you all know, can be easy to see. There could be rash. This diagram shows this sort of butterfly or malar type rash, but there's a variety of forms that we can see in lupus. And, there can be sores in the nose or mouth. There can be joint inflammation, arthritis, that is, and things that are not just in one specific area, fatigue, fevers. We can see low blood counts. And, when we look in the blood, we can see these positive autoantibodies, a reflection of the fact that lupus is an autoimmune disease, as you are all familiar, a situation where the immune system is attacking these various tissues and causing these various symptoms and problems. And, those problems can be most serious when it's one of the organs of the body, internal organs, that's being affected. We see this with inflammation around the heart or the lungs, which we call pericarditis or pleuritis. We can see lupus affect the brain, most dramatically perhaps leading to seizures or hallucinations, but a whole variety of effects can be seen that may be somewhat less striking. And of course, we can see inflammation in the kidneys, which we call nephritis. And, even this long list that I've gone through so far is by no means comprehensive. There's a number of other ways that lupus can affect someone and present. But thinking a little bit more about lupus in childhood, and by that I mean also adolescence, compared to lupus that arises in adults. When I diagnose a patient with lupus, parents are sometimes surprised, and they naturally say, oh, I didn't realize that people could get this as kids. And it's true that it is certainly more common to get as an adult, but probably around 1 in 6 of everyone who develops lupus will develop it before they turn 18. Usually that'll be in the teenage years, because we see a little step up when people at the pubertal sort of age in terms of onset, though people can develop it even younger than that. And one thing that we know is that lupus, when it develops in a child or adolescent, it tends on average to be more severe than in adults. Now, there's a lot of variability here, of course. Lupus is an extremely variable disease from person to person, and even over time in the same person. But we see that on average, there's more symptoms. The symptoms are more severe, more immunosuppression is often needed in children. And one aspect of this is that we see that the kidneys tend to be more involved as well. So, for example, about 60% of people who develop lupus as a child or adolescent will end up having lupus nephritis, whereas it's probably only about 40% of those who develop lupus as an adult. And about half of those who end up with lupus nephritis already have it at the time of their diagnosis, at the time that their symptoms come to a point that they get the testing necessary to make this diagnosis. The majority of people who develop it get it within the first 2 years or so. It's possible a person can have lupus for many years and only at that point have it start to affect their kidneys. But and our experience and what research sort of looking at large number of patients has shown is that most people who have lupus nephritis, it arises within the first year or two of their lupus becoming evident. So one thing that's a good thing is that we see that in the short term, by which I mean sort of over several years, children with lupus nephritis are less likely to have significant kidney damage that leads to decreased function of the kidneys compared to what we see with adults. To speculate a little bit, I think this may be driven by the fact that, children are younger, the kidneys sort of at a starting point are on average more healthy, and so there's a bit more reserve there. I think there could also be some things around some differences in reaching specialty care and so forth, but I'll admit that I have not done an in-depth investigation of the literature on that point. The sort of countering to that, of course, is that if a person develops lupus nephritis when they're young, then they have many more years in their life ahead of them that we want to make sure that things stay at bay and that their kidneys stay healthy. And so it could be that, in the long run, the risks somewhat balance out. It's, of course, very difficult for us to have firm estimates on this because treatment is always changing. And so, for example, a person who's had lupus for 30 years today, the treatments that were available when they were diagnosed are quite different from what someone who's just being diagnosed now is. And so it's always hard to project forward. But our hope is that, things, that the trends we see when we look back over the past few decades, as we look forward, will continue to have improvements. So just as a refresher, what does the kidney do, right? And why is it so important to maintain it? At a basic level, it filters the blood, and it does so in a way that allows the body to get rid of certain waste products. And along with that, it's critical to maintaining the right level of water, certain salts, sodium, potassium, for example, and keeping things in balance from a pH perspective in the body. It also plays an important role in regulating blood pressure. So these functions, are things that come to bear every moment of the day. And kidneys that are damaged and unable to do this as much can have significant impacts on people's well-being, as you can imagine. I also sort of put in italics some other functions that the kidney does that are sort of maybe not directly related to the blood filtration, you could say. And that is, they're important in helping stimulate red blood cell production through some hormones that they produce. And similarly, they play an important role in vitamin D metabolism. So why do we need to treat lupus nephritis? Why is it so important to stay on top of it? Because one thing that I'll get into in a moment is often a person, when the lupus nephritis is getting started, feels fine. There's nothing that they are experiencing that would tell them, oh, my kidneys are having inflammation right now. What we know is that untreated lupus nephritis results in damage to the kidneys, and that this damage can progress, usually over the span of years, though there's some variability there, until the kidneys cannot do their work. And at that point, dialysis or a kidney transplant would become necessary for a person to replace the function of the kidney that's been damaged. Obviously, we want to prevent that, and we know that effective treatment does reduce or stop that accumulation of damage. What we see is that lupus obviously is a serious disease, and even patients who don't have lupus nephritis can have very significant effects on their health. And particularly when we look at adults as they get older, whether they got the lupus as a child or as an adult, we see that they're at increased risk of dying earlier than a healthy person would. And we see that even among that lupus population, those with lupus nephritis are at increased risk as well. And so, having lupus nephritis is sort of a marker that this is on the more severe end, and important for us to work with the patient and make sure that they're getting the treatment they need to help with that. So how do we realize that there's this lupus nephritis in the first place? At a surface level, in every visit, people get a blood pressure check. And one thing that, as I mentioned, the kidney is very important in regulating blood pressure. And if the kidney is not working well, one thing that we can see is that the blood pressure can be altered. Almost always this would be high blood pressure. So we know that people with lupus, especially lupus nephritis, are at risk of having high blood pressure. And if we saw that, that could be one thing that would get our attention and help us want to look closer. Now, that can take some time to be seen, and we don't want to miss things and let things necessarily get to that point. So, we also use these blood tests and urine tests. The blood tests, and you may have seen this in your own blood results or your family members' blood results, are the creatinine and the BUN. And these are two waste products that are excreted by the kidney. And so if the kidneys aren't working well, those products tend to start to build up to a higher level. And that can be a sign that the kidneys aren't working as they should. However, the kidneys are resilient and we're built with a fair amount of reserve. So often inflammation has to be present for quite some time before those tests would become abnormal. And the goal is to catch this evidence of inflammation and start treatment before we get to that point. And that's where the urine tests are so important. And fundamentally, what we usually are looking for on these tests are blood and protein, because when the kidneys are working well, there is only a very small amount of protein that's in the urine, and there's more or less no blood cells that make it into it. So in these urine tests, they go off to the lab. The lab has one sort of machine that lets it measure the protein in the urine. It has another way where we can look at the urine under a microscope to see if there's any red blood cells, white blood cells, things like that there. And so, you may have heard these terms of proteinuria, which is protein in the urine, or hematuria, which is red blood cells in the urine. And, a lot of times the number of red blood cells may be very small. So the urine looks normal. You can't see a change that you would if there was a large amount of blood, but even that small abnormality will get our attention. And these urine tests are usually the first sign that the kidney is being affected, and they'll be something that drives us to want to look a little bit more closely. Sometimes we have enough information that we feel like lupus nephritis could be diagnosed without a direct look at the kidney itself. But most of the time, a biopsy is important because this gives us the most definite information on what's going on in the kidney. These tests here with the protein and the blood and the urine, there are other things that can cause this. And the treatment for these different causes of nephritis are not all the same. Although it's certainly true that if a person already has lupus and now they have nephritis, it's most likely that they're directly connected. That's not universally the case. In addition, there are different sort of ways that the nephritis can be present in the kidney, differences in severity, and a couple different sort of specific ways that it's affecting the kidney. And understanding that can help us understand the right approach to treatment. So these biopsies, which were performed usually by a pediatric nephrologist, sometimes they could be performed by a specialized radiologist, allow us to take a little sample of the kidney, and then the pathology doctors can look at that under a microscope, and they can try to understand what might be going on. Now, don't worry, there's no need to I'm not going to get into the details, but this is just sort of for a little insight as to what the pathologist looks at. These are photographs taken of microscopic images done in different ways that are from a kidney that does have lupus nephritis. And looking in these different ways, what the pathologist is trying to look for evidence of is there inflammation? So this often is in the form of there's white blood cells that are present there where there shouldn't be. There can be a look for structural changes in these sites where the blood is doing its active filtering, where the substances are coming out of the blood and going into the part of the kidney where they end up getting processed, and and urine comes out sort of the other end, or to see if there's scarring. And then, the other thing that can be true is there can be deposits of substances in the kidney. And, this greenish image in the bottom right is looking for that specifically, where we can, using a special stain, and we can have buildup of these proteins that are involved in the immune system's activity. But in lupus nephritis, when there's this inflammation there, they can build up and be associated with damage and help us understand what's going on. So when we've had this situation, we've gathered this information, we see that, there is lupus nephritis. It brings us to the next phase, treatment. What do we do next? And we divide this into two phases. The first one we call induction. And the goal here is to achieve remission of this active inflammation in the kidney. And then the second phase is maintenance, and the goal is to keep things quiet. We don't want flares. We don't want any additional kidney damage being built up. We want to keep things there. Now, the reason we separate these two is the medicines that we use in the first phase, on average, are a bit more intense than are needed in the second. It takes a little bit more to get things quiet than it does to hold them there in most situations. You know, a long time ago, by which I mean, say, the 1950s and before, there was unfortunately no treatments for lupus out there. If people developed lupus, it would progress on its way and would lead to, unfortunately, death for most people within a few years. And the first thing that really came on the scene that could make a difference were steroids. Prednisone being the most common, but some other steroids were tried as well. And so even today, steroids are a part of our treatment. But when this was first developed, they were the mainstay, and they were used at much higher doses for a longer period of time than we use now, because there was really nothing else out there. This did help with the nephritis. It did reduce damage, but it also, of course, brought many, many side effects. Even with the doses we use today, some of you have, I'm sure, no doubt, experienced, or your family members have experienced side effects from steroids. And so this has been a big push over the past 50 years of, can we have more medicines that are more effective and that allow us to sort of reduce the side effect burden that people experience. But still today, we have steroids as an important component. They start on a higher level, and then they work their way down. And for most people, they stay at a low level for a very long time. And, the other thing, of course, that's true is most people with lupus, it's recommended that they're on hydroxychloroquine. This is sort of a baseline thing. This is not really targeting the nephritis specifically, but it's pretty close to universal, so I mentioned it. So after, people were looking for, what can we do beyond steroids? What can we do that will work on top of that? And so the medicine that was arrived at was cyclophosphamide. And the first hint that this could be effective came, around the 1970s or so. And as with a lot of our treatments for lupus and other autoimmune diseases, the medications were originally developed with the idea of treating leukemia or other cancers. And then it was realized, if these at very high doses can affect white blood cells, maybe at more modest doses, we can affect white blood cells at a level that, controls inflammation without sort of being as, needs to be all the way to that point that we would use with cancer treatment. And that was the case here. And, just as a little example of some historical data that reinforce the idea that you could use cyclophosphamide, these are in people who already were on treatment and they had some improvement in their activity of the lupus nephritis. And this is really a graph of how likely they were to have a flare or not. And this is essentially the probability of not having a flare, okay, or a bad flare. And so you can see that over the span of a few years, most people on prednisone ended up having progression of their disease, whereas most people who were on prednisone and cyclophosphamide did not. So, this became the approach at that point in time, was the combination of prednisone and cyclophosphamide. And still today, some people have that as the core of their treatment. However, I'll just sort of also mention as a side point that the doses that were used then in those studies were actually cyclophosphamide, usually by mouth. Anyone who's gotten it today, I'm sure, is getting it in an IV form where it's not on a daily basis, but it's either every 2 weeks or every month, depending on the regimen that's been chosen to be used. And so the benefit, of course, is that reduction is, again, a reduction in the side effects that we see from cyclophosphamide, which especially at very high doses can be quite significant. And this is, I guess, as I'm sort of making clear, this is the big trend that we're always trying to balance in these treatments, is we want to be at a point where we can calm the inflammation and help with the nephritis, but at the same time, we want to be safe. We don't want to increase the risk of infections beyond what is safe. We want to try to minimize damage to bones or other sorts of damage that can come from some of these medicines. And so we're always working to try to strike a balance and working with you, the patients, to understand what you're experiencing as well to help us in that process. So as things are moving forward, people are trying to come up with regimens of the cyclophosphamide that work well, but are better from a side effect perspective. And people were also thinking, well, are there other medicines out there? Not everyone is helped by this. They're still challenging. You have to get it through an IV, all that sort of thing. So what can we do also? And so about 20 years ago, a medicine called mycophenolate came to the fore, and we began to have evidence that this could be an effective treatment for lupus nephritis. In particular, there were studies looking in adults that showed you could have good control of lupus nephritis, by which I mean quite similar effect to what we have with cyclophosphamide. Now, I'll just sort of mention, because I've been using the non-brand names of these medicines, cyclophosphamide, you may have heard called Cytoxan, and then mycophenolate, there's a couple different forms, but the brand names include Cellcept and Myfortic. So the nice thing about mycophenolate, of course, is it's a pill. It's not given through an IV. And the other nice thing about mycophenolate is that it's something that you can be on for a long time. The cyclophosphamide, now the way we use it is we use it up front as an induction agent, but we don't just keep going on it as a maintenance agent because, again, the longer you're on it, the more the side effects tend to build up. Whereas mycophenolate in many patients, we can go a very long time, safe, not a lot of side effects. That's obviously not universally true, and so we always try to work with people, but this is the core. So now this is sort of an outline of the typical sort of routes and ways that we can approach our treatment for lupus nephritis. Though I have not mentioned one thing that often gets included, and that is people are often on a particular kind of anti-hypertension medicine. That is a medicine that helps control blood pressure. That's in the sort of ACE inhibitor, or this is called an angiotensin receptor blocker antibody. So lisinopril is from this first category. The reason these are chosen is this gets at the sort of way that kidneys affect blood pressure. And it's also been found that being on these medicines in lupus nephritis and some other diseases can be beneficial to the health of the kidney, sort of, even though it's not directly reducing the inflammation itself. And so the decision of whether to go on that is usually made by the pediatric nephrologist, the kidney specialist, but is something that I often do see used. So what do we do if we use those medicines and they don't seem to be working? We're not getting improvements. And by that, I mean things like the amount of protein in the urine is going down. The blood is going away. If the kidney's function had been disrupted, is that stabilizing or perhaps even improving as there's a little bit of healing? What do we do if that's not what we're seeing? So I've listed here some of the options, which I won't go into great detail, but I'll mention a little bit. We have medicines that these work in different ways than the medicines I've mentioned so far. And so sometimes as an alternative, or more often sort of as an add-on to the medicines I already mentioned, we can go to them. The medicine rituximab. This is an infusion that helps get rid of the B cells in the body. And B cells are one of the types of white blood cells. They make antibodies, and we know they play an important role in driving lupus and lupus nephritis. There's a family of medicines that include tacrolimus, and then we use this less often, cyclosporin, but these are in the same family. There's a medicine called azathioprine, which used to be used a lot for maintenance. It's been around for a long time, and it does work, but it seems to work not quite as well as mycophenolate, and so that's sort of fallen out of being used most commonly, but there are situations where it's the right choice. And then excitingly, we have some new choices out there. We've gone quite some time without really having an expansion in the medications that we could go to, but in the past few years, we've had a couple new ones that have become available to us. One of them is belimumab, so the trade name for this is Benlysta, and it was approved last year for children 5 and up with active lupus nephritis. and this making it one of the only medications to have that designation. And, over the past decade before that, it had various approvals for sort of other lupus-related situations, either in adults or general lupus and so forth. You might be thinking, well, if this is the only one that has that approval, how are we using these other medicines? And it is because of the understanding that often medicines go through the rigorous study to treat a particular disease in a particular group of patients, say adults. And then once that's been shown and they've been approved, there may not be an incentive to repeat all those studies in children or for a slightly different situation. There's a tendency, especially in pediatrics, to carefully implement use of what's called off-label prescription, where a medicine that's approved, it's known to be safe, and it's been shown to be effective in a certain situation, is used in a slightly different situation because that's the best option that's available. And then finally, of course, I shouldn't say of course, but finally, there's a medicine called voclosporin. This has been approved in 2021 for adults with active lupus nephritis. This is actually in the same sort of family as tacrolimus and cyclosporin, and this is another option that can be used. Being used more in adults, I would say at this point, but it can be used in that sort of off-label way for children and adolescents if that seems to be the right choice. So how well do these treatments work? Well, and this is speaking generally, there's a lot of variability depending on exactly where you look and how you define remission. But about half of the time, we get to remission of the lupus nephritis within 6 months, meaning that on the current medicines, we've gotten rid of the protein or it's at a minimal level. We don't have the blood there. The kidneys are working stably. And over the next 6 months, probably another 10 to 15% of kids can get to that full remission. So that leaves still about a third of patients. And many of them do see some improvement, just not as all the way to where we'd like to see it happen. And then, there can be situations where, and this is the kind of situations in which we'll be using these other medications. Sometimes as soon as a few months in, if we're not seeing the kinds of improvements on the usual sort of set of medicines that I mentioned, we may start adding some other things in, but this is the state of things. And this is, I think, the evidence that there's still room for improvement, certainly. And we still want to, as a field, come up with new options to help patients more universally be able to get to this remission. And alongside that, we're always, of course, thinking about, can we have new ways that are easier to take, have fewer side effects, or just less disruptive, and help people, be able to be thriving and living the life that they want to be leading. So I want to transition now to looking forward. What are we working on? What are some of the things that are coming in the future? And one important thing that I want to mention that I think, fortunately, well, in the past as a field in medicine and in rheumatology specifically, I don't think we've done all we can to. And I hope that as a field, and from what I'm seeing, we're focusing on this more, and that's addressing the disparities that we see. So, foundationally, what we see is that lupus is more common in Asian, Hispanic, and Black patients. And among patients with lupus, those same populations are more likely to have nephritis. And there's an increased risk of severity and progression to kidney damage in those groups, the highest with Black patients. So this is a disparity where the outcomes are not equal between people if you sort of look at these ways that they could be self-classified. One thing that we know is that these disparities are at least largely, some disparities are probably entirely, but this one is at least largely due to structural racism and other non-biological factors. These are things that are not intrinsic to the fact that someone has a particular ancestry or self-classification, but instead is reflections of how society is structured and the kinds of broader lives that people on average are living. And so it's essential for us to work to better understand the drivers of these disparities and work to address these structural issues in order to see the kinds of equivalent care and equivalent outcome that is deserved by all patients. So this is a big point of emphasis. Another current effort is around refining some of what we could call consensus treatment plans. This is a little bit more of a narrow thing, but something that I'm more familiar with because of some work that I do with CARA, which is the Childhood Arthritis and Rheumatology Research Alliance. So these plans are not rigid guidelines, but they're more a document produced by a group of experts in the field through discussion around these are a few different approaches to treating a particular disease, in this case, lupus nephritis, that people feel are all reasonable, and we don't really have the evidence to say one is better than another. The last of these was written about 10 years ago. You don't need to try to zoom in, but this is an example of like a component of it. And so it notes that, you do cyclophosphamide or mycophenolate to start, and then it has a few different steroid tapers you would choose from. And the idea is that it might be good for people to sort of generally adhere to one of these, and then through the CARA registry and other efforts, we could gather information over time to get a sense of, are one of these routes actually a little bit better? And so, right now work's going on in rewriting this and modifying it. Some of the things that are being thought about are an update to the steroid dosing regimen, which in general, this will probably be a move towards a quicker taper based on what we've been able to see in terms of what can be effective. And, the European Pediatric Rheumatology Group put out a new steroid dosing plan last year that they think is a reasonable one. It'll likely include a second sort of dosing regimen for cyclophosphamide that a lot of people have been finding effective, and that in adults has been shown to be equivalent, at least in many patients, to the one that was used longer ago, and still in certain situations. And then being a little more formal about like, when does it make sense to use rituximab or some of these other treatments? Like, how long should we wait? What would be a good sign to bring that medicine on board? And there's also some talk around combined lupus nephritis clinics, because some places have these, which, it's like you see both the pediatric rheumatologist and the pediatric nephrologist at the same time, but running these clinics can be tricky. And so I think there's work to understand how are they actually better for patients, both by their experience and how things go, and how can they be run in the best way possible. To transition a little bit to research that's looking ahead a little bit more even, I mentioned some tests earlier on that we use to try to diagnose and monitor how lupus nephritis is going. But there's a continued effort to find new blood and urine tests that'll give us insight that'll be more accurate, or perhaps give us information without a biopsy. We often call these biomarkers because they sort of are a lab test that represents what's going on deeper in the body. One of these that's probably closest to entering widespread use is something called anti-C1Q, but there's others that have been researched on. It takes a long time because you have to gather the evidence that it actually is better than what we're already using. And then, of course, you have to actually have it available for someone to order. There have to be labs that are all set up to do this in a safe and reliable way. And I'll also mention, there are clinical trials that look at biomarkers. We often think of clinical trials looking at treatments, but there are clinical trials that look at biomarkers to try to figure out if they provide additional helpful information. And I've pulled just a couple here, which aren't fruiting yet, but are anticipated, that we'll be looking at a component called C4D in childhood lupus nephritis, or looking at a couple other biomarkers, and in this case, seeing if this could help with diagnosing lupus nephritis. And then finally, thinking about current research on treatment. And this will lead into a bit of what Dr. Kim will be talking about in much greater detail after me. But I just took a look. There's an international clinical trials database, though it's actually run out of the US, clinicaltrials.gov. And if you just narrow down to active or upcoming clinical trials for lupus nephritis, there are 77 listed. So a lot of work being done there. Now, 21 of them include people under 18 years old. And a lot of times what these are doing is attempting to demonstrate in adolescents what has already been shown in adults. And that's actually the case for these 3 examples I showed here. I mentioned that medication of voclosporin. There's a plan to do a trial where now, instead of looking at adults with lupus nephritis, we're looking at adolescents. And then there's some trials that are actively recruiting. One, which you'll hear in much more detail about from Dr. Kim, about a medicine called obinutuzumab. And then there's been previous trials of this medicine with adults. And then just as an example, and this last one actually is being done outside the United States. This is being done in China, I believe, looking at mycophenolate versus cyclophosphamide. That's what those 2 are. I already mentioned that in our own practice, based on the fact that in adults, we've seen equivalence between those are both being used, and observationally, they seem to both work well, but this Chinese group is planning to look, at least in China, perhaps because their own practice pattern is a little different right now, to see that they're equivalent, or perhaps that the mycophenolate, that one of them is superior to the other. There's other studies that are going to look to see if we can be giving more effective dosing. Maybe we can do blood tests to look at levels and see if that will help with making the most effect from mycophenolate possible. And then finally, just as a brief mention, there are some therapies that are being looked at for sort of last line. These wouldn't be first line things, but things that if everything else doesn't seem to work, what could we have in reserve? And this group looked at a group of just five patients, who had extremely severe lupus that couldn't be controlled by standard treatments. And they used what was called CAR T-cell therapy. This is a therapy that over the last 10 years has been brought to bear for treatment of certain kinds of cancer. And they did a somewhat modified version of that, the core of which is you take a type of white blood cell called a T cell out of the patient, you genetically modify it so it will now attack the patient's B cells, and you put it back in. And they did see that it was very effective, but this is a very elaborate procedure, has significant side effects, is very expensive because it's personalized, and so it's never going to be a first-line treatment. But as continued research goes on, this may become an option for those in whom all the more standard treatments don't get us the result we want. So in summary, talked about lupus nephritis overall and noted that it affects more than half of all children and adolescents with lupus. Talked about how we come to the diagnosis of lupus nephritis through, in particular, urine tests and then more definitively kidney biopsy. I've walked through our current standard treatment approaches, which are often built around mycophenolate and cyclophosphamide, and that these result in a complete remission in about 2/3 of patients and some improvement in many others, but not all. And I've outlined some of the research that's ongoing in new ways to provide more equitable and effective care for our patients. So with that, I just want to acknowledge the rest of the pediatric rheumatology team at UCSF, my patients and their families who are a constant source of learning and inspiration for me, and some other references there. And again, I want to thank the Lupus Foundation of Northern California for inviting me to give this talk, and look forward to taking any questions after Dr. Kim has shared her own presentation. Thanks.
Thank you, Dr. LaFlam. That was so informative and comprehensive. Now, I would like to introduce our next speaker, Dr. Susan Kim. Dr. Kim is a pediatric rheumatologist and clinical professor of pediatrics at UCSF Medical School. Since 2006, Dr. Kim has specialized in caring for children and adolescents with inflammatory rheumatic diseases, including systemic lupus erythematosus, and focuses on clinical research in pediatric rheumatology. She leads the Pediatric Rheumatology dermatology clinic at UCSF and has leadership positions in CARA, the Childhood Arthritis and Rheumatology Research Alliance, which is an international research organization in hopes of advancing care and research in the field of pediatric rheumatology. Welcome, Dr. Kim.
Thanks so much, Krista. Thanks for that kind introduction, and thanks to Dr. LaFlam for that great presentation. Dr. LaFlam's talk really highlights the great need for treatments and better treatments, especially proven treatments for lupus and lupus nephritis and kidney disease. So in the next 15 minutes or so, I'd like to briefly review why treating lupus nephritis or kidney disease is so important, especially in our younger patients, and just explain clinical research a little more to you and what might be involved in being part of clinical research and why it's important. And then just let you know about this research trial that's going on that is also being run out of our program, if it might be of interest to you or other members of your family. So, you know, lupus nephritis, it's really important to treat because of all the inflammation in the kidneys that occurs. It's much more common, as Dr. LaFlam highlighted, in younger people compared to adults. And it's very serious, and there are very limited treatment options that exist. So developing better treatments for young individuals is really important. As Dr. LaFlam highlighted, lupus is more common in females compared to males, and the same is true for the kidney disease of lupus. And then it's much more common in lupus is much more common in non-white patients compared to white patients. And lupus nephritis also is much more common in non-white patients compared to white patients. So we have a lot to learn. So yeah, I wanted to let you know about this POSTERITY trial that's being run with UCSF being an arm of it. It's a clinical study that's going to evaluate how safe and effective this medicine called obinutuzumab is in combination with the standard treatment for lupus nephritis, which is the mycophenolate that Dr. LaFlam had mentioned. And there's this great little video that was put together by the team just telling you about what a clinical research study is. So I'm just going to play the video and hopefully you find it helpful. And here we go. sorry, it's come to my attention during the slideshow that you guys couldn't hear the audio that goes along with it. So I really apologize for that. But I think in the interest of time, we'll move on. But the POSTERITY study enrolls teenage patients between the ages of 13 and 18 who have kidney disease, who are being treated with mycophenolate. And a portion of patients, 2 out of 3 patients enrolled into the study, get the study medicine called obinutuzumab, and 1 out of 3 get what we call placebo. And that sounds kind of tricky because why would you give some people the medicine and not another proportion of the population medicine? That sounds very confusing. And why would you do that? And the reason we do that is not because we want to not give people medicines that are going to be helpful, but we need a lot of information to prove that medications are helpful and that any side effects that are associated with medications are not so bad that they aren't worth using that medication. So it really is to show that medicines are effective, but also safe. Because if they are effective but not safe, then they're not worth using. If they are safe but not helpful, we don't want to use those either. So we need a group of patients that actually don't get the medicine. The doctors and the researchers actually, while you're getting a medicine like that in a study like this, are blinded to which group you are in during a portion of the study, because we don't want the doctors to just think that, oh, you're getting that medicine, so of course you're better, and not be objective about whether or not someone's improved or not. So that's a short summary of what the study is. There's a screening period to be part of the study. And then, as I said, you either get the study medicine or a placebo, which is like a sugar pill, basically. And then you get standard treatment, like what everyone gets today for lupus nephritis, which is MMF or mycophenolate mofetil and steroids. And that's over an 18-month period. And safety is monitored for 12 months. If patients do well, you can get more of the medicine as part of the study too. And then additional safety is monitored for additional 12 months. Usually, if you decide to be part of the study, because we want to make sure over a long period of time that the medicine's safe, you have a commitment of about 2 years and sometimes more. So this medicine is called obinutuzumab. The way lupus attacks the body is when your immune system hyperactivates, and there's one set of blood cells called B cells that usually make antibodies that help protect you against infections like bacteria and viruses. But in lupus, it makes what we call bad antibodies, like double-stranded DNA, if you're familiar with that from your lab tests. So this obinutuzumab medicine very, very effectively blocks B cells from making antibodies. And it's thought that by doing this, you'll treat lupus better. In a previous study of this medicine, it was found to improve kidney health in adults with lupus nephritis. And we really need to see that this helps teenagers and younger individuals also, because kids aren't just small versions of adults. Kids are different from adults, especially because they continue to grow. Their metabolism is different. And there are a lot of differences between adults and younger individuals. So this study is important. And then, yeah, so taking part in the POSTERITY study, We're looking for individuals between the ages of 12 and 18 who are diagnosed with kidney disease or lupus nephritis that should be severe to a certain level with a certain amount of protein in your urine. And the great thing about this study is that there is a lot of support related to attending the study visits and reimbursement for travel and meals and other expenses for the time that's needed to be part of this study. And then instead of coming for all of your clinic visits, sometimes a mobile nurse can be provided if suitable to participate in the study. If you're interested in learning more, I put this QR code that you can scan to get to the site to tell you more about the study. It's also on clinicaltrials.gov, as Dr. LaFlam mentioned. And if you have more interest to talk to our research coordinator, I've put a number here as well. Thanks for your attention.
Thank you, Dr. Kim, for the opportunity to hear about the POSTERITY trial. Now we will open the Q&A portion of the event. We will begin with the questions that were asked during the presentation. Feel free to ask additional questions while we are talking. We will try to get through as many questions as we can live, and we'll email you answers to any questions that we are not able to get to today. So one of the questions that we received was, how can I make the best use of my time with my child's doctor during their appointments?
Yeah, so that's a great question, and much appreciated to have someone really thinking about that, because it's I can imagine that sometimes the visits feel quite compressed. I think what I might say is that it's helpful to come to the visit with having thought beforehand about what are you concerned about and what are your questions that you want to get answered. Like, sort of have a sense of like, what's my priority for this visit? What do I want to be sure to get out of it? And hopefully your doctor early on, there will be an opportunity in the conversation for you to sort of make that clear. And that way, my hope is that in the visit, that can be sure to be addressed. There can be a focus on that. So that's one thing that I guess I would recommend that might be helpful. I don't know if Dr. Kim has any additional thoughts on that.
Yeah, no, I totally agree with that. I think really important because visits are hectic and busy and overwhelming with all these people working with you and seeing you, and maybe things running not quite on time. Having a list, definitely having a list of what you want to talk about or what you've been thinking about that needs to be addressed, because I know that always helps me organize my thoughts and make sure I don't forget in the context of a busy visit. Another quick thing is that I think that if there isn't enough time at one visit to address all your questions, I think things like telemedicine or phone visits are becoming more and more possible and accessible at different sites. So seeing if those could be arranged with your rheumatologist as well. So maybe an extra visit in between your usual in-person visits is also something that could be possible with your rheumatologist.
Great, thank you, Dr. Kim and Dr. LaFlam. Our next question is, besides medications, how else can I help my child?
Thank you for the question. My presentation focused on the medication because that's what I'm most directly, I suppose, in control for. But you are hitting on the fact that thinking about the whole child, the whole sort of aspect of life is important. I'll mention a few things that I think are true. And some of these really, frankly, apply, I suppose, to the health of everyone and not just those with lupus. One thing is that I think things that overall would be healthy for everyone are probably, especially so for people with lupus or another chronic disease. These are things like trying to get regular sleep, get enough sleep, having a diet that is overall balanced and healthy, there's no specific diet where like I can recommend where it's like, oh, if you avoid these things, it reduces the inflammation. But, you know, a generally healthy diet where there's plenty of fruits and vegetables, modest levels of sugar, things along those lines. And opportunities for being physically active, perhaps at times taking account in the middle of a flare, if there's a lot of arthritis, how you may not be able to do that. But in general, trying to be able to have physical activity and things like that, I think that's one part. I think a second part is working to make sure that other aspects of the child's health are thought about, like getting all the recommended vaccines. And I think a third thing I'll just mention is sun protection. You know, even for people with lupus who don't have rashes or other skin things, getting exposure to the sun without sunscreen or without wearing hats and things like that sometimes can provoke things a little bit. And so I think it's important for everyone with lupus to really be using the tools they can to make sure that they're not getting unprotected sun exposure while still having the opportunity to be, you know, outside and doing things that are fun.
Maybe I'll just add a couple more things. I think working closely with your social worker and pediatrician to optimize psychosocial supports. So all the things that we have in our control, that we can control, like our diet, our sleep, our exercise, and sun exposure. But other things I think we can try to support is school stresses and what kind of supports we could get at school, and what kind of mental health supports we can get to support stress that could be involved with having a chronic illness. So I encourage everyone to work as closely as you can with your local social worker and school. Thanks.
Great. Our next question is, you mentioned that kids may be on ACE inhibitors. Are there any side effects?
I will briefly address this, but I will admit I don't prescribe these medications directly. Usually the nephrologists do, and so they may have a more comprehensive set. What I will say is that sometimes on ACE inhibitors, people can develop a cough, actually, and occasionally that's severe enough that it ends up needing to be changed to an alternative medication. And then there are also just certain other health situations that need to be taken into account to think about if an ACE inhibitor is the right one. I think it's just always, of course, important if someone is planning to prescribe that to just, you know, ask that question to the doctor at that time. But in general, ACE inhibitors are used, especially a lot with many adults who have high blood pressure or other, you know, reasons to be on them. And in general, they are a safe medicine without a ton of side effects.
Yeah, I would agree that usually there are very few side effects associated with that medication. That class of medications called ACE inhibitors. Just like with all of the medicines you take regularly, labs are monitored closely, like your salt levels in your body, but that's almost never an issue. Sometimes you could have issues with maybe some dizziness or fatigue, but that's very, very, very uncommon. And if side effects do occur, doses are usually modified or decreased, and then the medicine's usually really well tolerated. But ACE inhibitors are thought to be more and more important for long-term, maybe what we call protection of the kidneys. Thanks.
Great. Thank you, Dr. LaFlam and Dr. Kim. We really appreciate your time and expertise. Thank you. Now we will have our next speaker come join us.